Thanks everybody for joining us today. Welcome to our first session of our community of practice on prevention and practice behavioral health amongst individuals with disabilities. This presentation is provided to you by the National Center for Health and Public Housing. Before we continue, we have a few reminders here that all participants are muted upon entry. Please make sure to also engage in the chat if you have any questions or anything you'd like to share with us today. These community of practice sessions are meant to be engaging and also help stimulate more of a learning experience for all of our participants today. So please don't be shy. And whenever we go through all of our questions and case studies, please feel free to unmute your line as well if you would like your line to be unmuted and participate verbally. Or if you're not able to do that, you can also provide your responses in the chat. This meeting is also being recorded. The slides and recorded link will be sent to you all via email after today's session. And of course, we always like to know more about our audience. So please let us know in the chat your name, the state that you're joining us from, the name of your organization, your title, and what specifically brings you here today. So thanks everybody, and I already see some.
We've got New Mexico on the line. What else do we have?
Yeah, awesome.
Rep your zip code. Tennessee, love it.
Welcome everybody. Thank you for participating.
Okay, we got Sunbelt. Yes, okay, we've got Illinois now too. I hear the weather's been hard up there. Spring's coming. Any East Coast, West Coast? We've got Idaho. Oh, fabulous. We've got folks from all over the country today. This is great.
Yeah.
These
Well, thanks,
sessions are an opportunity for us to, as you can see, every so often I'll just get a handful of people from the same state, but we've got a large breadth here. These sessions are an opportunity for us to share ideas, share practices, share challenges, and the different parts of the country means we've got a lot of diversity here. So that's great.
Yeah. Awesome. Welcome, everybody. Thank you so much. All right, so about the National Center for Health and Public Housing. So our mission is to strengthen the capacity of all federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. The content of this webinar is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of the U.S. government. So about us, very quickly. So with me on the line, we have our wonderful Dr. Kevin Lombardi. He is our Director of Research at the National Center for Health and Public Housing. If you'd like to learn more about him, you can always go to our website and also contact him via email. We're going to provide our contact information at the end of the session. My name is Fide Pineda. I am the TTA manager here at NCHPH as well. And I know that over here we have our health communications or research analyst. Unfortunately, she's not able to join us today, but she will be joining us in our next sessions. And now, without further ado, I'll pass it on to Dr. Kevin Lombardi to get us started.
Hi, everyone. Pleasure to meet you. I'm Dr. Lombardi. Call me Kevin, please. I'm a medical doctor and epidemiologist. My clinical background starts with paramedicine prior to medical school, training in internal medicine and epidemiology. I am a health systems guy. Specifically, my expertise is working with FQHCs to institute program change, in particular in the areas of the social determinants of health and behavioral health, and program evaluation and population health. My publications focus primarily on medical protocol compliance and the treatment of underserved populations in emergency departments. This community practice is focused is the term is very broad. We're focusing on individuals with disabilities. I will be taking slices of those that I think are particularly relevant to the FQHC context, and to the audience. The first two will focus heavily on individuals with SUD co-occurring with a intellectual or physical disability. And we will probe at the particular circumstances that drive addiction in this population, and the particular sensitivities we must have, and the contextual factors that make folks either more resilient or less resilient to SUD. We're going to have a lot of fun doing this. The way I teach is typically I start with the macro and then go down to the micro. The macro being the public health environment and the pathophysiology of the condition. How many folks have this? And what drives the condition inside the body. We will then go to a case study and look at the human experiential element of it, and by taking what I think are fringe but core cases of individuals with these conditions and their struggles with the healthcare system, their families, and so forth. It is through the primary care context, but it's have really focused on the post-care environment, which, seeing from what we have here in our group of colleagues, is exactly what you all do for a living, the post-care context. So I hope this will help to ground patient care within our shared experience of caring for these patients, and enlighten all of us of each other's professional worlds. We are a mesh that works together to promote community and public health. The more we know about each other and the better we can speak each other's languages, the more effective we can coordinate care. The more effective we can coordinate care, the healthier our patients are, and the more financially healthy our healthcare institutions are. Let's do it. Next slide, please. We've got Kansas here too now. We're gonna get the whole middle of the country here today. Lovely. Fabulous. So I kind of just went through the learning objectives, so we'll skip this. I'm always harsh on the learning objectives slide. And give me a second as I pull it up on my screen here. So, as I said, we're going to start with the epidemiology here. I create these as consulting style conversations. I was a healthcare consultant in one of my past lives. The All of the citations are really good. They're papers I've read, and I believe balance scientific rigor with accessibility. These are things that I would recommend printing out and reading with colleagues. Do you have a book group? People love book groups. Do you like book groups, Fide? Well, let me give you a
Yes.
book group
Mhm.
idea. It's called Scientific Paper Review. And it has a less fun name, but it is just as fun. Print out one of these papers with your colleagues, read them, and have a book group style meeting. This is what physicians do to understand protocols. This is what other healthcare professionals do in their training, and there's no reason we should stop doing that. That's what keeps us on top of things. So these are all good coffee table papers for you to print out, put on your desk, read with your colleagues, and understand issues that are important to you professionally and to the lives of your patient on a deeper level. It also makes you much more fluid in conversation when you are talking about these things. If you are reading them regularly and reading scientific literature regularly, you are what you eat and you are what you read to a certain extent. So please follow the citations, print them out, have fun with them. So we start with an epidemiological analysis. We know Susan's going to print them out. Great. Okay, we got one. We got one. Let me know how the book group goes. Anyway, Uh, just to look at the size of the population and to emphasize its commonality in our society, and whether you are from Idaho or from Kansas. Researchers have found that disability is associated with a 1.43x, which is equivalent to a 43% greater odds of daily nicotine use. I know we have a tobacco coordinator here. Individuals with disability indicated a reduced risk of alcohol use. And researchers have found that's about 33% lower. And researchers have found that disability, and this is both intellectual and physical, associated with 1.99x or a 99% greater odds of prescription drug misuse. Those are really big numbers. If you have a group of, say, 100 of individuals with various types of intellectual or physical disabilities, say they're your patients, you would expect, say, if you were to expect 10 of them to have some sort of substance use disorder, then you would now expect 14 of them, or in the case of tobacco, or 20, close to 20 of them if you were talking about prescription drug use. Overpopulations, that means there's a lot of extra patients, which means this is relevant. These patients are in the community. They are not always identified, but we're going to get better of that through screening. But your knowledge of the size of this population is an important thing to put in the back of your head, because these patients are not always identified and their care is complex. Um, Next slide. People don't go around screaming, I smoke and I use prescription drugs, in particular youth with disabilities. There are a number of barriers that stop this from being identified. They may have communication deficits that stop them from telling their parents. They may have, like any youth, an incentive not to tell their parents. The parents may not have the active role in their life that is required to be able to notice when these things are happening. Um, I like to always just expect that those dynamics are existing in some way because that puts the onus on you to notice it. Now, when I think of patient care, I like to think of the internal locus and the external locus. Fide, have you heard me talk about the internal locus and external locus before?
I believe so, but if you could remind everybody.
Yeah, I bring it up socially as well sometimes, because it's just such a great way of looking at the world. For your patients, in particular youth with disabilities, there are things you cannot control. There is the nature of their disability, the nature of the limitations that they have, increased risk of using SUD due to social environments you cannot control, due to lack of interest or participation of parents that you cannot control. Now, our social workers in the line have a little more control than people like me, but we are still limited. That's the external locus. I like to think about the internal locus, which are the things that I can do as a provider, and being able to spot the condition, being able to screen for it, and being able to provide targeted support are the things that I can do or my colleagues can do. So these are the things that I focus on, and we're going to probe at those a little bit in a moment. Next slide, please. So, some more epidemiology, and if I don't know if I mentioned, but we will be going through a detailed case study that's really fun in towards the end of our session. Young adults with disabilities experience higher levels of mental health and substance use conditions. This has been exacerbated by the pandemic and post-pandemic period, which we still are in. By the way, individuals that were diagnosed for the first time 4 to 5 years ago, or 6 to 7, depending on how you frame it, they are still managing these conditions. And the rates went up significantly in the last 5 years. 38.8% reported new substance use during the pandemic. These are substance use disorders which are still current, many of them. 30.6% had seriously considered suicide in the past 30 days. and 56.6% reported symptoms of anxiety or depression. And these are new onset. Now, typically, when an individual without an intellectual or physical disability were to get a new diagnosis like this, these are challenging times. For an individual with the added constraint of a physical or an intellectual disability, the transition into the new life of managing that condition is particularly challenging. And there are often treatment gaps that build up over time. So of note, we are still in the period where it's appropriate to first time diagnose a lot of folks that just have not been diagnosed. And that's particularly true of children and youth, pediatric patients. Next slide, please. I am not a pediatrician, but I work with a lot that have very strong opinions. So let's just break down SUD for a while. Substance use disorder doesn't, oftentimes you may think when you look at folks, what's the difference between someone who ends up having SUD and someone who does not? What are the causal elements here? If we can understand that, maybe we can intervene, right? And I like to pick these three. One, there are the biological factors. There are certain genetic or physiological uh, elements of human beings that make them just more likely to use substances, tobacco, and I'm talking about tobacco, alcohol, controlled substances, as well as marijuana. These as a group. We'll get into one of those in a minute, which is the tendency towards impulsivity is one of them. But these are drivers that make someone more or less likely to use SUD in a given circumstance. Does it make them guaranteed? No. There is no gene you can look at and say that person will have a SUD. It is all contextual. It is a rope of probabilities together, woven together. The physiological factors, such as personality traits or comorbid psychiatric conditions, are major drivers as well. We know from the literature that individuals with anxiety disorder in particular are much more likely to use tobacco. Now, I know a lot of anxious people, and in my own life, I've noticed they are more likely to smoke. You may notice this as well. And it's because of the physiological effects of nicotine. Nicotine serves as a very short-term anxiety releaser. In the long term, it helps build that anxiety and makes it worse over time. But the physiological effects of the nicotine act as short-term relief for people who have anxiety, and thus they're more likely to do it. There are reasons for this in a physiological way, and those are other drivers and the related needs factors. So we're talking about the STOH survey here, things like peer pressure, SUD use in the community network, and so forth. These are things that expose the individual to that SUD. Well, if you don't have exposure, you're not um, uh, going to use it. It's not there. But if you have the exposure and you have the physiological factors, you have other risk factors, each one of these elements makes it more likely that in that circumstance, those individuals would use SUD. So it is contextual and it is complex, but I wanted to give you a perspective of that. Next slide, please. So I've got some questions. Before we get into our case study, so the way I do questions is I read them, I sit back and ponder, and I ask you all to put things in the chat or raise your hand and give your thoughts. You don't need to be podcast ready. You don't need to be the most articulate. You need to be a professional with experience and an opinion, which all of you are. I would love to hear from you as much as possible so we can probe. I will probe in a light way, I will say. And if I don't get anything from you, I always probe Fide as well. So Fide, be ready for me. I may do it anyway too.
Yes.
She loves it. She thinks it's fun. She gets to learn all these cool things. So I think you will too. So based on your experience serving youth with disabilities in whatever context, what do you think are the risk factors for substance use in this group? What do you see? And how do you manage those risk factors? I gave you some hints in the last slide, but we'll take a minute. Environment. That's my favorite one because it's the most interesting. Um, uh, Fernua, one, correct me if I'm pronouncing your name incorrectly. I'm known for that. And two, tell
Thank
me
you.
what you mean by environment because I don't know what that means and I don't understand.
Okay.
Neither does Fide. Can you hear us?
I can hear you.
So, what do you mean by environment? Why did that come to mind for you?
The people, the actual neighborhoods, opportunities for interaction with people that are older that may have access to things that could actually be given to the youth with disabilities, or even sometimes they're family members that will provide them with things. That's why I said the environment.
Yeah. So isn't that shocking when that does happen? And isn't it shocking how common that is?
I think both. Yeah, you're right. I really have seen a lot of people that not only do they take their children or take youth around things, but they actively encourage them to engage in some of the practices. Like they'll give them their cigarettes, they'll give them a cigar, they'll give them
Yeah.
alcohol.
Wow. That's what we're working against. And it's such a big barrier. I like how you describe that and I like how you mention it because it is true and it is real. Uh, Depending on the neighborhood that someone lives in, depending on their family makeup, their social context, they could be receiving exposure constantly from and I won't pick you on you anymore. Thank you so much for sharing. But can you tell us one more thing? Can you tell us who you serve, how you serve them, and where? That's three things, not two.
I actually work with residents in the public housing setting, but also the neighborhoods around them. And sometimes I'm in and out of the different schools with our residents and their, that are participants of the programs.
Mm-hmm.
So that's what
Yes.
I'm saying about the proximity, about sometimes the interaction that you see not only in the home, but the surrounding neighborhoods as well. And so education and reinforcement from peers has really been a tool that we use to basically take down the use of tobacco, take down the use of drugs, because, basically what we try to do is have them model those practices that we talk about in health classes and everything at the school and at home. So they get to say no, and then their peers actually help reinforce that.
Hmm. Can I ask what part of the country?
Tennessee. No.
Tennessee.
Mhm.
Lovely. You're 100% correct. The thing that comes to my mind in particular with regards to residents of public housing is the exposure to tobacco for young folks is quite high. The rates of smoking in public housing facilities and developments are roughly twice the general population. So that's twice as much exposure. So 100%, and thank you for sharing that. Anyone else? This is a good one. Lack of activities with positive role models. I think you guys saw my slides beforehand. Susan, why does that matter? Why should I care about lack of role models? What does that have to do with healthcare?
I've noticed in our community, we're really small, we're really rural. We do have some great positive role models. However, they're not easily accessible to our youth because a lot of them are farmers and ranchers and they're not participating in that. So what happens is we see for lack of a better term, I'm doing my master's in social work right now, so I'm struggling to make sure I have the right term. But I would put them in the category of like stragglers that don't have parents involved in their life start moving with other people who do have that, but start influencing them. Because I notice the peer pressure up there, because a lot of this is like full circle where one thing is just constantly impounding the other. But the positive role models, seeing people that are doing something with their life and encouraging those children, giving them positive feedback when they are doing something well and productive, it really makes a huge difference. I noticed that with our kids in football back home in California.
Mm, 100%. You mentioned a master's of social work. Did you say you are getting it or you have it?
I'm working on it right now so that I can do disease management, SUD here, and behavioral health counseling for disease management in addition to that.
Well, you sound just like one already, and congratulations. That's very rewarding and important work. So, I've worked and lived in rural communities for a long periods in my life. I trained in Danville, Virginia, in the southern part of the state of Virginia, and spent some time in Coahoma, Mississippi. Both rural areas that were very demographically different, but they shared that element. By definition, in a rural area, people are spread out. And the jobs that tend to take folks away from the community are very difficult. You mentioned your farmers and your ranchers. They're not available to be role models because they're taking care of cows or they're planting seeds or they're doing something. And the folks that happen to be around aren't always the best, uh, let's say, role models for kids. This is a consistent thing that folks that live in communities like you do mention. And it happens in our urban communities as well. It happens all over the countries, of course, all of the country, of course. But who really suffers are the youth that aren't able to set a baseline of what normal adulthood is, of what normal responsible behavior is. It is the lack of a counterfactual. If all you see is men or women smoking, doing drugs, if it is normalized, it becomes a cultural norm within your family, within your community. And that removes a huge barrier from stopping it because it's normal. It's not abnormal anymore. You'd be interested to know that many folks who use these substances don't know that it's a disease. It's just normal. I just use it every so often. Well, I've used it every week for the past 5 years. That's SUD. That's not normal. You have to bridge a gap and provide them with the right information. Thank you for doing what you do and for serving who you serve and for sharing. We have got a case study to get to. Fide, do you have any ideas? I need to hear from you before we proceed.
No, I think most of the responses were in line with what I was thinking, like not fitting in with peers, like peer pressure. Those could be some of the risk factors as well. So,
Well, 100%. Now let's probe into those a little more. Next slide. So let's talk about risk factors. Risk factors are those in your internal locus or your external locus? What do you think, Fide? Internal or external? Control or no? Do you control the risk factors?
external. I think
Nope, it's both.
both. Okay.
It's a trick question. Gotcha. You're the only one that gets the trick questions. No one else gets those. Um, it is both things, because often you can make a difference in them. You cannot take a child in a difficult home environment and pick them up and put them in a better home environment. You're correct. But at the same time, you can support the family and help to institute changes. So you may not control it 100%, but you can influence it. So that's where we cite our social workers and community health workers and tell them thank you for your service because this is their profession. and it is very difficult. But I want to focus on a few here. These are the ones that are highlighted the most in the literature as quantitatively driving this condition. But difficulties with peers is one that's very important. In particular, with youth, certain youth with disabilities can be very sensitive to rejection from peers, and they can be very easily influenced by those in their social environment. Think of someone who has an intellectual disability. They may not possess the executive function to be able to say no to something in a social environment. Uh, if they are exposed to that, uh, the likelihood of them using the substance is just higher. It's an increased risk, and it's an important risk for these individuals. Now, imagine that same individual with an intellectual disability and their father is using something, or their uncle is. It's much easier for this suggestion to drive behavior change in those individuals because of that cognitive risk. Those who experience physical disabilities may have chronic pain, even at a young age, that makes them more likely to use substances because they make that pain go away, either physical or emotional. Oftentimes, those things are one and the same, and by one and the same, I mean co-occurring. Um, so, lack of daytime activities as well. This is a baseline risk for everyone, but in particular for youth with disabilities. Youth with disabilities that are doing things, sports, structured activities, church groups, music, acting, uh, any activity that gets them doing something positive and building something, a skill, a activity, a skill, a competency, so forth, is getting them away from that exposure. And that structure provides resilience in their brain because of the social feedback. Imagine a child in a music program who is loved music, loves singing, and goes to choir every week. They get the positive social support of all the individuals they're doing it with. They get the feeling of being equal and a peer with someone, and they are not exposed to bad outcomes at that time. And there's a feedback loop too. The performance, the doing things out with friends, the social connection, it supports their mental and emotional resilience. So substance use disorder or using a substance becomes less of a risk because it has less appeal. Structure for youth is the way to go, especially individuals with disabilities, especially. And poor living conditions. Individuals who live in dangerous neighborhoods, who live in substandard housing, are going to be more likely to leave the home and be exposed to social environments where substance use may be normalized. Next slide, please. This is a big one, substance use by role models. Um, it normalizes. And even when you talk to folks as adults and they who are struggling with alcohol use, substance use, and aren't aware they're struggling because they feel like they have it under control, you can often root that assumption in the use of the substances by a caregiver when they were younger. It is hugely influential even to adults. Now imagine someone with a cognitive disability. That is that emphasis or that direction, that the driving effect of that is proportionally larger in those individuals. They are more easily persuaded, depending on their disability. They may be more easily persuaded or manipulated, and they are at unique risk of the medical complications of using those substances. So, substance use by role models is important. It is something to screen for. It is something to keep an eye out for as well. And of course, the disability itself is hugely influential on someone's risk. Some individuals with disability might not have have a very low or not have an increased risk of SUD, depending on their disability. Mild or borderline intellectual disability has been identified in the literature as particularly at risk. These are the individuals that are more easily persuaded or influenced by peers or role models. And these are the individuals which we must be particularly wary of. It is our responsibility to look out for them when others do not. And that's for the vulnerable in general, not just those with mild or borderline intellectual disability. The risk here is real, though. Next slide. Now let's look at the protective factors. What makes those youth less likely? Now, this is an area of research that I started in as an undergraduate. My first research job was with a professor who studied substance use in youth in Alaska and indigenous communities. Now, these are areas that are known for having the highest rates of suicide and substance abuse in the world amongst youth. What they found in their community was the more that kids got involved with native cultural activities, hunting, fishing, and so forth, the more resilient they were. And when I think of that, and I think of our last slide, I think of the diversity that we can, of how we can get youth involved in things that promote resilience. There is a thing in your community that is cultural, that is community driven, that exposes folks to mentors. Find that and refer these youth to those programs. Maybe a church organization. If it's Alaska, it may be hunting or fishing. But the importance is exposure to role models and exposure to activities which teach them things and help build confidence and competence. So just to go through my slide here, social, emotional, behavioral, cognitive, and moral competence, of course, are protective factors. These drive understanding and understanding of risk in particular. An individual's belief that they can modify, control, or abstain from substance abuse is a major part of cognitive behavioral therapy and very important in creating resilience. If they do not believe that they can abstain from it, they are more likely to take it. But when they believe that that has turned into their internal locus and they control it, they are more likely to exercise that power. But often you must reveal that to them and be explicit. And finally, involvement in spiritual or religious practices across the board. Doesn't matter if it's a church, a mosque, or a pagoda. Involving folks in religious activities is shown by the research to increase resilience across the board to substance abuse for this population. Next slide. There is a source down there, by the way, if you want to read some more protected factors and some more details. I was not able to sum it all. Some more risk factors. So each session, I'm going to take a personality trait and break it down and give you a screener to test for it. And I want to start first with impulsivity. And I'm not talking about the colloquial term. I'm talking about the clinical term. For youth with SUD, their likelihood of substance use is heavily dependent on personality type, with each presenting unique risks and methods for treatment. For youth with SUD, screening for and understanding their personality type is a great way to understand the routes for treatment. So these individuals often lack the ability to delay a behavioral response when faced with immediate reinforcement, results in greater experimentation, difficulty with delay of gratification, and lower inhibition in social settings. This personality trait often co-occurs with aggression, rule breaking, or ADHD-like behaviors. And these, of course, also drive that substance use risk. Next slide, please. Now, how do we manage it? One, education, cognitive behavioral therapy. Explain the link between impulsive decisions and negative outcomes. So when they are in that circumstance again, and they are considering it, that negative outcome is now in that part of the file cabinet. The more they understand that, the more they are likely to avoid the behavior. Skills training and rehearsal, practice the stop and think strategies. The stop, think about what you're doing, and think about the consequences for high risk situations, such as being offered a cigarette, being offered alcohol, peer pressure, these sorts of things. When you're working with the patients, you identify those circumstances that they are exposed to, and you work through them hypothetically with them so that they understand where they have control or where they can stop things. When they receive that training, they are more likely to say no. And there's a great source in the bottom left for Susan for your coffee group. Consider this one. Next slide, please. Behavioral rehearsal with immediate reinforcement, kind of going through it, literally act the stuff out with them. It makes it more real, and more real is more replicable. And more replicable is, I can never say that word more than twice in a row, is more replicable is provides a framework and a structure in their mind. And when there is a framework and a structure, they're less likely to knee jerk to that impulse decision and make the correct decision, which is no, I'm fine, thank you. Now, I just described a mental process. Now, that mental process is a result of the education. So when you work through patients with these things, you are building an internal mental structure. It is like putting scaffolding up or building something. It is a physical neurological structure in the brain, which you facilitated creating when you talked about this. So it's not just a conversation, it's building. Think of it like that. Next slide, please. I'm going to tell you all about Jordan now. Case study mode. Vida, are you ready?
Yeah, ready.
Cool. Well, I'm going to tell you about a case study in the primary care context. I'm going to have some questions for you and your colleagues. It is going to be complex. You may not understand all of it, but you are going to understand a piece of it. And we're going to break it down so that you understand all of them. Because disability, SUD, are rarely in isolation. They are in a soup of comorbidities and risk factors. So let's try to understand the soup and see if we can parse the ingredients. Jordan's a 17-year-old male with a history of mild intellectual disability, IQ of 68, ADHD combined type, and type 1 diabetes, who presents at his primary care appointment with his grandmother. Jordan is insulin dependent and uses a Dexcom G6 continuous glucose monitor. Jordan presents today, 1 week after visiting the ER for delayed hypoglycemia, which occurred after alcohol intoxication. Okay, next slide. A review of Jordan's chart, his medical records, also reveals the following. 2 emergency department visits have occurred in the past 3 years due to hypoglycemia following alcohol exposure. Experimental cannabis and alcohol use beginning at age 14. No current SUD diagnosis. Attends special education classes. Jordan, of course, lives alone with his grandmother. His school records note increasing impulsivity, risk-taking, and conflict with peers. Now take a second and look over those because these are going to be important. Next slide, please. You perform a focused interview with Jordan and his grandmother. The following is reported and recorded. Jordan has exhibited an increase in conflict-driven behavior. He regularly leaves the house without telling anyone, just leaves. His grandmother is concerned he is being influenced by older teens in the neighborhood. Jordan is noted to be, quote, always looking for something exciting. He has received 2 recent school suspensions for aggressive, impulsive outbursts. Throughout the interview, Jordan remains withdrawn and resists interaction. Next slide. So he's got a Dexcom, so that means we can look at it. Okay. You review the data feed and it indicates the following. Can anyone make sense of this to me? He has the Dexcom and has a little thing that's attached to his hip. It reads his glucose and it sends it to his phone. And his phone has a live read of it. So grandma and him can both look at it and see it. Now, he just went to the emergency room for hypoglycemia after drinking alcohol, which happens in type 1 diabetic patients. And you asked to look at his Dexcom, and this is what you see. And what does it say? Does anyone have a thought?
It looks like he went into a severe hypoglycemia. He dropped below 60, possibly down into the maybe 40s. I'm not sure how many that jumps. It's pretty low.
Hmm. If you were to point in the graph with your finger and say when you think he was drinking alcohol, where would you point?
This is on the 7 days. I actually know the answer to this because I do type 1, so I don't know if you want me to answer.
I do want you to answer, and I want you to say as much as you want to say. Yes, I picked the right
Um,
person.
if I remember correctly, it can be 5 to 10 days prior.
So typically there is a reflex hypoglycemia that is very close to the drinking episode. So in this case, for this individual, who drank an excessive amount in a short period of time, his body is not able to metabolize the aspects of alcohol of someone who does not have type 1 diabetes. So he experienced a very severe drop. So we would expect him to have that a little bit before that urgent low right there. Now, it says here that his blood glucose went as low as 55. Why should I care about that? That's just half of 100. That's above zero, right?
Because it needs to be at least 70.
Mm-hmm. 100%. So that is dangerously low. It is not quite at risk for hypoglycemic shock. I have seen people in the 30s. But 55 is extremely concerning, and it makes the trip to the ER make a lot more sense. So that's our read. Let's go to the next slide. So you remember the brief sensation seeking scale. We're going to do this on Jordan. Let's take a look at the results. So, next slide, please. Thank you. We ask him if he likes exploring strange places. 4, I get restless when I spend. It's a 1 to 5. Restless when I spend too much time at home. 5 explains the leaving the house. I like to do frightening things. 4, Jordan's pretty extreme. He likes wild parties. This is a classic impulsivity sensation seeking individual. His average score is 4.4, indicating high sensation seeking. Next slide, please. So, I will say first before this that this individual, Jordan, is someone who would benefit from cognitive behavioral therapy that helps him to stop and understand his decisions, as we discussed earlier. When you see patients like Jordan, provide them with the framework to better understand their circumstances. That leads to resilience. But how does behavioral problems intersect with his medical conditions? I think we just saw an example, but does anyone have thoughts of how those connect?
Type ones generally have to kind of follow a regular regimen with the schedule, and their activity, their food intake, the level of nutrition, any type of substance use, all of those things can dramatically affect the readings that they get on there, how much sleep they're getting, if the sleep is solid, um, expending extra energy, like everything affects type one.
100%. And when you describe those, I think of volatility. And with our type 1 diabetes patients, we want their blood glucose to be fairly stable. Stability in blood glucose requires the routine that you mentioned. Uh, it also requires stability in life, in diet, in social interactions, and so forth. So, someone like Jordan, who is regularly out of the house, leaving the home, is engaging in alcohol and substance use experimentally and in large volumes, that it introduces volatility to his body and lifestyle in a way that greatly destabilizes his blood glucose. It makes it even more likely that he experience a drop like that. Is he eating when he goes out? Who knows? What is he eating? Is he eating anything he wants? Is he, he's unlikely to be chomping on broccoli when he leaves the home to go spend time with his friends. So his behavioral health problems are driving his risk for hypoglycemia. And these two things are co-occurring and woven together. And I picked Jordan for this reason, is because when individuals experience disability and substance abuse disorder or risk of substance use, they are rarely in isolation. There are many patients like Jordan. And the important thing to emphasize here is really impact over time. For someone like Jordan, who is a youth, less than 18, I think he's 16, if you are able to build scaffolding in the brain uh, that promotes resilience, that understanding I talked about, the stop and think, the thinking through consequences and having a process for doing that because someone walked you through that. That is something that will stay with them for their whole lives. It's sticky, and it's sticky because it works. They may not do it immediately, but the time these experiences accumulate over time. So when you promote resilience at a young age, you are creating the possibility of resilience for a lifetime.
Okay. A quick
Oh,
question.
100%. Susan's talking about the fluctuations in blood sugar. So typically when individuals go below 70, and you can see this even in the 80s, depending on the individual, what their baseline is and what the change from baseline is. You can experience severe cognitive defects, in particular with executive functioning. So when I see that and I think of Jordan, I think that this is also involved. If he's leaving home, he's skipping a meal, his glucose may be 71, 72, and or it might be lower. And as a result, his existing cognitive defect or deficit is now made exacerbated by a reduction in executive function because of that hypoglycemia. Nice catch, Susan. Nice catch. Do you have any thoughts for us? Can you do a victory lap for us? Because that was very insightful.
I don't know about a victory lap, but I do know some of the teams that I've dealt with. I previously worked as a nurse in the school district, and there's a lot of times the teachers didn't understand the process of their type one and whether they're high or low and how their decision making abilities can be, as well as how they react to things. Just like, when we get hungry, even though we're not type ones, I know my husband can get pretty grouchy if I don't feed him every 2 hours like a baby. So I know with the sugars being up and down in people, you definitely already get a different reaction from things. But I think a lot of people, yeah, don't think about that. So yeah, thank you. I know what I've seen, and it's kind of scary sometimes that people just think it's, oh, well, they're weird or they're misbehaving or not acknowledging that there's some relationship with that as well.
Hmm. Yes, and it's important to say these things so that that recognition is more widespread. It is, they call them reactions for a reason. They are reacting to a low blood glucose. Your brain needs a lot of sugar, and as soon as you reach below that threshold, it starts to cut functioning. Think of it as like an engine room, and they have to shut down part of the engine. That's what the brain does. And the output is cognitive thought and self-awareness. So that output goes down. It goes down.
Yeah.
So 100%.
Yes. Kevin, I believe Renew also had a question.
Yes. So in this case, both he and his grandmother have access to the app and see the readings. Um, so both the grandmother and him have the app. And they both know how to use it as well. I will say that that is not always the case, but in this case it is. Next slide, please. Next slide. The next steps, this is a complex question that will take us a while. I think we'll pick this up next time. Um, uh, but for Jordan, I am going to want to look through his diabetes care and go through his regimen in detail. I'm going to want to know how his grandmother is involved. I'm going to want to know his eating schedule. I'm going to want to know more details about his behavioral issues to see if they are driving that, and I'm going to want to probe at the triggers for substance use, exposure, and so forth. I will focus on his risk factors when I am applying programmatic support. And that will be different everywhere depending on what is available. And I will focus on longitudinal care through provision of a CHW or a social worker for this individual. That is what they need. Next slide, please. I gave you a screener today, so I want to talk a little about screeners. Screeners are great when they're used in the beginning and at another assessment point because you have something to assess. The impulsivity score I gave you is yet one example. It is not static. Um, uh, Impulsivity from a behavioral health perspective is not a static thing. As you teach your patients more about coping mechanisms and increase the scaffolding of understanding in their minds, when you take a second BSS, which is typically recommended for patients who are in a program such as a peer support program or a cognitive behavioral program, beginning and the end of treatment, you will notice that those scores will change. And if your therapy is targeted and individuals are receiving it well, you may notice it go down. And with that goes down the risk. Um, um, yes, next slide. Here's my Dr. Lombardi system for CHW management. I recommend a coaching style system, starting with intake with CHW that focuses on goal setting for whatever treatment. Follow-up engagement, depending on the patient's severity, it should be longitudinal, and I mean up to 6 months or longer. Navigation is a primary focus of the meetings, and coaching is a focus of the meeting, depending on the goals and the programs or resources that are being used. And case closure happens when your initial reasons for referral have been addressed in all of the ways that you can address them in your capacity. And I say it like that because resources are different in different areas. So there's a different basket everywhere. So that is my system. Contact me if you need more details about that.
Great. Well, thank you so much, Kevin Lombardi, and thank you to all of the participants that were able to engage in today's session. So we have now concluded today's presentation. This is just a brief reminder that we have our upcoming sessions next week on the same day, on Wednesday at the same time at 1 p.m. So we look forward to seeing you all next week, and please make sure you use the same link that you used today to join our future sessions. In our next session, we're going to talk more about evidence-based prevention approaches for substance use disorders. So we look forward to seeing you all next week. And please complete your post-evaluation. You will be receiving a follow-up email with the link to it as well. And that's it. Here's our contact information. And we thank you so much. Thank you, everyone. And see you all next week. Bye-bye.
Thank you for serving your communities as well. Bye.